Our group has been involved in the first clinical trial with the CD38 targeting antibody daratumumab. In the GEN 501 study, patients were treated first with very low doses with daratumumab, and when that appeared to be safe, there was a phase 2 expansion which showed the efficacy of monotherapy daratumumab in extensively pretreated patients. And importantly, the toxicity profile was very good, with only infusion reactions as the major adverse event, and these occur in 50% of the patients, mostly during the first infusion, but can be well managed by temporarily stopping the infusion and giving some extra medication in some cases, such as antihistamines and steroids. These patients in the first monotherapy trial were extensively pretreated patients for whom there were no other treatment options available anymore. And because we saw a clear signal in these end-stage patients, of course, also other less advanced patients were selected for daratumumab therapy. And in these less advanced patients, daratumumab was also combined with other anti-myeloma agents in order to improve the outcome. So two major phase 3 trials have recently been published. One which evaluated the combination of daratumumab with Velcade, dexamethasone, and the other phase 3 study which evaluated daratumumab plus Lendex versus Lendex alone. And both studies showed a clear advantage of the 3-drug combination versus the 2-drug combination in terms of response, progression-free survival, and both again with a very good tolerability profile. I think the triplet combination of daratumumab with Lendex and daratumumab with Velcade-Dex will become one of the standards for the treatment of myeloma patients with 1 to 3 prior lines of therapy because it's very effective, well tolerated. But we also have other triplet regimens which can be considered, and you really have to look at the type of relapse, the patient factors, maybe in the future also biomarkers, to select and to pick the best triple regimen for your individual patient. And still, you can consider 2-drug regimens in patients with very indolent relapses, or maybe even in frail patients, in which the toxicity of a 3-drug regimen is too high, and you can better go for a 2-drug regimen. So for example, for daratumumab, we have been looking in the immune system, and we have identified some interesting biomarkers. We have also looked at a target expression in terms of predicting response. However, there is considerable overlap still between responders and no responders for these biomarkers. So we have not yet identified a biomarker that really predicts yes or no with a very great sensitivity that a patient will respond or not. So CD38 is also expressed in the conductive tissue in the heart. It's expressed in glial cells in the brain. It's expressed in the lung. And although it's expressed in many tissues, we do not see any toxicity occurring there. The main toxicity, as already mentioned, is an infusion reaction, which can be managed quite well. And for the rest, daratumumab is very well tolerated. We have to get more knowledge about the long-term effects of treatment with daratumumab, but up till now there is no other safety signal occurring. I think that's maybe with the daratumumab monotherapy study, we have now patients on it for 3-4 years with continuing response. So yeah, and I expect that in the POLLUX study, in the CASTLE study, patients will also be on daratumumab for long periods of time. One more important thing to mention, and that is that because of the good tolerability, the efficacy in the relapse setting, daratumumab is now also shifting towards first-line treatment. So in the Netherlands and in France and also in Belgium, the HOVON IFM study is now recruiting patients to also evaluate the added value of daratumumab in combination with VTD induction in newly diagnosed transplant-eligible patients. So the results of this study will also be very relevant and important. The study is still enrolling patients until August well, until fall next year, we expect. And then we need some additional follow-up before we have the final results.